agents that you can use to treat the sleep problem. No, but I want to add, I want to use an agent like quetiapine because I'll get some benefit in terms of its antipsychotic effect. I'll get some of that benefit in addition to the fact that it's going to help my patient sleep. It does nothing to the D2 receptor. The D2 receptor, which is where the antipsychotic property resides, quetiapine is not going to mess, the dose that you use is not going to touch the D2 receptor because it has such weak affinity. The point being, use Benadryl. I mean, if you're trying to use an antihistaminic, if that's the property of quetiapine that you're depending on, use a more specific antihistaminic. So in terms of treating comorbid conditions, there are other alternatives. What about a different route of administration, as you brought up, that you use a long-acting injectable like a flufenazine decanoate or haloperidol decanoate? It may occasionally be appropriate, but it needs to be specifically targeted and its utility confirmed by monitoring. So it's not as though if you're using it for the purpose of, have different routes of administration, one IM, one oral, reasonable, but show that, it's useful for this particular patient. What about, I've reached the maximum dose of the first agent, as you mentioned, Sahas, that I've reached the maximum dose of olanzapine, 20 milligrams per day. What do I do now? Well, there are three possible things that one can consider doing. One, if you've reached the maximum dose of that medication and the patient's a little better, if it's no change at all, switch. But if the patient's a little better, what do? Well, a switch might still not be unreasonable, or might you go increase the dose of the agent beyond the FDA maximum. And if you look at Dr. Buchanan's presentation and the port guidelines for olanzapine, quetiapine, and ziprasidone, the highest FDA dose was asterisk, and aripiprazole, suggesting that there are certainly some suggestions and data suggesting that you might want to go up on the dose of that particular agent beyond the FDA maximum. The data are most compelling for olanzapine. I mean, because there have been trials of olanzapine at doses of 30 milligrams per day and up to 40 milligrams per day. But for the other medications, the data are not compelling, but certainly suggestive. So if you've reached the maximum dose of the first agent, no benefit, switch. If you've got some benefit, well, might you consider an increase in dose beyond the FDA maximum? Certainly not unreasonable for a number of these medications. Might you switch? Might this be the time that you try clozapine? What about, let's move to data. Okay, so these are the explanations that are propounded for combining two or more antipsychotics. And as you can see, there are alternative strategies that are more reasonable before you get to antipsychotic combinations, if you will. But are there data on antipsychotic polypharmacy? And in fact, there are. You've got a couple of handouts in your packet which look at two different sets of analyses. One, a meta-analysis conducted by Christophe Correll and others from Hillside Hospital, and the other, a joint commission review of this particular topic of antipsychotic polypharmacy, again, using much of the same data. 22 randomized controlled clinical trials of antipsychotic polypharmacy compared to a single antipsychotic agent. The evidence for benefit of antipsychotic polypharmacy is weak, relatively weak, and even this benefit, how much of the benefit that you see is because studies which are negative are not published. And so in fact, when they do the funnel analysis, when they do these different analyses to see if there might be a file draw problem, they find that there is a strong hint of a file draw problem. Combinations including clozapine with a potent D2 agent, clozapine plus a potent D2 agent, this is where you see more evidence of benefit. There are other indications, other markers of antipsychotic polypharmacy being more effective. If the study is conducted in China, for example, so if you look at the different indicators of suggestions why antipsychotic polypharmacy might be found to be more effective, Those are some of the observations. But clearly, there is a role, particularly for clozapine plus, in those patients who've responded in part to clozapine, adequate clozapine levels. The problem with antipsychotic polypharmacy is clearly there is a greater risk of adverse effects. It's costly, and not costly just in terms of money, but costly in terms of side effects as well. So in summary, why is two or more antipsychotics a complex care indicator? Well, because the evidence for utility is fairly slim. If one looks at the rationale, there are alternatives. There is some evidence of reduced safety. What's surprising about studies of antipsychotic polypharmacy, by the way, is the prediction would be it's really bad. You're going to have terrible side effects. In actually studies of antipsychotic polypharmacy don't find such terrible side effects. They do find an increase in adverse effects, but it's not a glaring difference between polypharmacy and monotherapy. But there clearly is evidence of reduced safety, particularly from a metabolic perspective. And very importantly, if one thinks about the guidelines that we agreed to for the pharmacological treatment of schizophrenia, it's very low in the hierarchy of strategies to be considered during antipsychotic treatment. And that's the reason why use of two or more antipsychotics concurrently is a complex care indicator. Now, right now, this is how we've operationalized it. Is this the way we want to retain its definition? Do we want to modify it? So concurrent use of two or more antipsychotics for 60 or more days, and a higher level of scrutiny for concurrent use of 3 or more antipsychotics for 60 or more days. Thank you very much. Dan, do you want to kind of formally...
Let's have a hand for the presenter today.